Hello, everybody. I apologize. Like we're having a little bit of trouble with the picture for some reason. So we'll continue and hope that you can hear me. If somebody could just send a chat to me about whether you can, I would really appreciate that. Okay. If not, I will just go ahead. I am Dr. Steve Johnson, and this evening's live stream is on the conceptualization of emotions. Excuse me. It looks like we're having. Okay, it does look like you can hear me, so I do apologize for the fact that you can't see me, although that may be a blessing for all of you. I do want to again say that I am Dr. Johnson, and this evening's live stream is on REBT's conceptualization of emotion. It's a question and answer period. So if at any point you have any questions whatsoever, please just send me a chat and I will answer those questions. I do have questions that were submitted to me by different people, not only my students, but some people around the world during the week who also saw the video lecture. So I have those written down and I will sequentially go through those. So again, anytime you have a question, just send me a chat and I'll be more than happy to address it. The first question is, someone says, I noticed that REBT has an ideal vocabulary for emotions, both functional and dysfunctional. Is it important to use these? So in other words, I suppose I mean, is it important for the therapist to use that ideal vocabulary for emotions? And I have supplied that to all the students in my class. It is not obligatory, and if the client wants to use another word for their emotions, we will go with whatever they say. The only reason we like to have an ideal vocabulary is so that the therapist and the client can kind of be on the same page and understand each other when they're talking about an emotion. But sometimes a client wants to use another word, and that's perfectly legitimate, and we as therapists need to go along with that. If, however, we don't stick with the REBT ideal vocabulary for emotions, then it is incumbent on the counselor or the therapist to assess whether whatever the label is for the emotion that the client is giving, to assess whether that emotion is functional or dysfunctional. And I hope you remember how we do that. It's really straightforward. We simply check with the client whether when they're experiencing this emotion, do they have difficulty reaching getting their daily chores done, reaching their daily goals, whether those are interpersonal with their loved ones or friends or on the job or educationally, spiritually, whatever their goals are or their task. Does that emotion get in the way? If it does get in the way, then it is dysfunctional. Okay, and so it's quite simple to assess that. If you have any questions, feel free to follow up with me on that one here tonight through the chat. The second question was, I understand that in the REBT conceptualization of emotions, that the therapist looks at the emotion, the inference associated with it, all the relevant dysfunctional beliefs, and the behaviors that are typically seen. However, why does REBT leave out the physiological responses that are going on in the body? Now, that is an excellent question. And I'm really glad that someone was sharp enough to pick up on that. In more complete discussions of what makes up the conceptualization of emotions, we do cover those physiological responses. In this course, I gave a briefer explanation for it, but when I have much more time and can stretch that out over a few weeks, then I do look at the physiological responses. Not only that, But we also look at what's called the phenomenological component. I know, big word. All that means is how does it feel inside the client's body? We might have them describe that. So they might say, oh, I have this jittery feeling in my stomach or in my chest. I get dizzy or whatever. So, yeah, that's how it feels in their body. That's the phenomenological expression. And then the other thing that we often do when we're talking about this emotion is to look at three very important things. And it's always important to assess for these. And I will be looking at that later in the semester. That is to look at the frequency of the emotion. How often is it occurring in the life of the client? Is it happening daily or weekly, several times a day? Maybe it just happens once. Maybe it's anger. It only happens at Thanksgiving when the in-laws are over. But so the frequency is one thing. The intensity of it, how much energy is in that emotion when the client experiences it, and the duration. How long does it last? So, for example, if they're anxious, how long does that anxiety last? How long does that depression last? How long does that anger episode last? So, frequency, intensity, and duration. So, while it is important to look at the emotion, the inferences, the beliefs, and the actions associated with it, it is important to look at those other components too. So, again, thank you very, very much for asking that excellent question. The third one is REBT open to using measures of emotions, such as the BDI or the BAI? Just for those of you, this is probably a therapist. The BDI is the Beck Depression Inventory, and the BAI is the Beck Anxiety Inventory. Both really good measures of one, depression, and the other, anxiety. Yes, we do. I'm not covering those in this particular class because I have a whole range of students, some of whom are going to be therapists, some of them are going to be pastoral counselors, some may be clergy, some are going to be police officers. And so in those other kinds of professions outside of clinical counseling, they probably wouldn't be using those measures, so I don't cover them. I use those in some more advanced level grad courses where I do cover those in great detail. But yes, we do use those measures, and we use them rather frequently. Why? Well, it does give us a picture of a snapshot of what the client is experiencing right then and there. But also, we can track the scores on those instruments from session to session and see whether there seems to be a gradual improvement or it's staying the same or even getting worse, which is all very important information. So again, thank you very much for asking that question. The next one is fascinating. I've never had anybody ask this question, so I was really quite excited to get it. It says, number 4, why doesn't REBT look at the conceptualization of behaviors? Well, you know what? We absolutely could. But since the behavior is part of the conceptualization of the emotion, you could say in some sense, by looking at the behaviors and the specific behaviors exhibited by that individual with that emotion, we are kind of doing a conceptualization of the behavior. We just happen to call it the conceptualization of emotion. It could have been called the conceptualization of behavior. So really good question, though. Really good. Why is it that we're conceptualizing the emotion, but we're not saying that we're conceptualizing the behavior when both are equally important? As you can imagine, if somebody has a really distressing emotion, we want to help them with that. But also, maybe they're engaging in behaviors that really are causing a lot of trouble. Maybe they're yelling and screaming, or they're handing work in late, or they're coming to work late, or they're procrastinating, or any number of behaviors that are really not helpful for them to attain their life goals or important goals. So we would be looking at those. Number 5 says, isn't it judgmental to identify or label emotions as dysfunctional? Shouldn't we validate a client's emotions? Now, this is a tremendously important question. But it also hinges on what do we mean when we say validate a client's emotions. And I think we have to be very careful here. Sometimes when we say that we're validating a client's emotions, we are saying that their emotions are helpful or not helpful. Well, I don't want to validate an emotion by saying it's helpful if it's not helpful. I'm not helping the client then. Other times, somebody means by validating the emotion is acknowledging that the individual has that emotion. Yes, of course, we're going to validate it by acknowledging that the individual has the emotion, and we'll validate that they have the emotion with typical kind of calmness and non-judgmentalism that will go along with that. Sometimes by validation of the emotion, the person wants to know whether the emotion is normal or not. Well, almost any human emotion is normal, but that's not the issue. The issue is the emotion helpful? Because somebody could have a perfectly normal emotion, but it may not be helpful. It's normal, statistically normal to experience anxiety or depression or anxiety. It's typically normal statistically. 35 million Americans on a good day have some kind of anxiety disorder. So yes, of course, it's normal, but it tends not to be helpful in terms of sabotaging us in terms of reaching our goals. So I think we have to be careful with validating. When we validate, of course, we'll say it's normal, but we'll be certain to point out by what they are reporting that even they themselves are saying that it's not helpful. And so that we could work together, we could collaborate with the client to help them overcome that emotion and have one that might be more helpful, just as normal, but far more helpful. Okay, I think that's a powerful form of validation rather than saying, what you are experiencing is really good and there's no need to change it. I don't think that's really helpful to a client. 6, when assessing a client's emotions, isn't it helpful to ask ourselves how we would feel in the same or similar situation? I'm really impressed with these questions. This is an extremely, extremely important question, and one that I think we have to approach with great, great caution for some particular reasons that I want to raise. One, keep in mind that if you as the therapist have experienced something that is close to what the client experiences, that you may have a greater likelihood of projecting how you experienced it upon them and think that they have a similar emotion or similar behavioral response. And that is not helpful because you're not the one that's being assessed. The client is the one that's being assessed. And we don't want to have anything within our mind that will get in the way of our objective assessment of the client. Okay, so I think it's really important that we look at that. And I think there's another reason. For empathy, it is important that we try to understand what it must be like from the client's viewpoint to the degree that we can. That's important for empathy. However, there's a tendency, as I said, if we've come close to having a similar experience, that we will be imposing or projecting upon them what we had experienced, and that is not helpful. In fact, that could really get in the way of you helping the client. So for empathy, yeah, and so we do want to have empathy, but do not get so empathic that you get bogged down and think that you understand exactly what the client's going through. You don't. And so it's really important for you to listen very carefully to the client and make a very good judgment there. 7, you said that the inference for anxiety is typically that there's some form of threat that is present. Sometimes it's important to know that there's a threat so we can take some kind of protective action. So why is it dysfunctional to attribute threat to a situation? Again, these are really excellent questions. Let me be very clear. when a client or when we ourselves attribute to a situation that it is a threat, that attribution of threat alone is not a problem. It's only a problem when certain things are in place. One, if the individual is repeatedly seeing threat in the environment where there is no threat, that's a problem. That's problematical. If the individual, now look, the brain is an organ whose primary function is to see patterns within the world. And it's really important, specifically, and one of the most important tasks of the brain is to see potential threat. Because if we don't see threat, then we may be harmed or killed or whatever. So it's really, the brain is biased towards seeing threat. But the brain's not perfect. The brain will sometimes see threat when there is no threat. And if an individual has gone through some major experiences before, they're going to be more likely to see threat even where there is no threat. The problem with seeing threat when there is no threat is that the individual repeatedly experiences anxiety or depression or fear or any number of things that they really wouldn't need to, because the brain is interested in the survival of the individual, not happiness. And to be happy, you have to survive. So the brain is biased towards survival. So it will make mistakes, more likely to see threat when there is no threat than not to see threat when there is a threat. Okay, so the other problem is if the client is seeing these threats as overwhelming threat and that there's nothing that they can do about it, that is not helpful at all. That can inhibit them taking protective action. Or they see the threat, or they infer that there's a threat, and that rather than see that it's only a partial threat. If the client sees threat to the degree that they are unable to see the opportunity that might exist in the face of that threat, that's problematical too. Because a lot of times there can be potential threat, but if an individual sees opportunity for any number of kinds of things, an opportunity for deeper meaning, an opportunity for greater purpose in your life, an opportunity for deepened relationships or opportunities for skill building. If we see overwhelming threat but no opportunity, we may not have experienced those other good things that come from the presence of that threat. Okay, I hope that's helpful. Number 8, you said that the inference for depression is often that there is some kind of loss. That's absolutely true. Isn't it important to identify the loss so that the client can go through the normal stages of grief? That's a very creative question, and one that I want to handle in a couple of ways. One, within psychology today, and especially within counseling, we have moved far away from believing in the stages of grief because there's hardly any empirical evidence that would support that there are actual stages of grief. And in fact, if we believe and impose the stages of grief upon the client, we could really disrupt the therapy. For example, one in the old stage theory of grief, one of the stages was anger. But a lot of people don't get angry when they're grieving. And so I have heard clients say, oh, they're blocking. They're not allowing themselves to experience anger. Well, that's very judgmental. Maybe they're just not angry. Maybe they have beliefs that don't yield anger. So to the stage theory could be really, condescending in many ways, and kind of taking a patriarchal, superior attitude that I know what stages you should be going through and you don't. Well, that's ridiculous. And so the way that we look at it now is not that there are stages of grief, but there are certain tasks. Like one of the tasks is to find meaning in life, because sometimes when we've had a major loss, we lose some meaning or purpose. So to re-find meaning, maybe a different meaning, re-find a different purpose, make new connections in life, and have a relationship. For example, if it's the loss of a loved one, to have a different relationship with the deceased person. You're going to continue to have a relationship, but they're no longer there. You're going to think about them and remember them fondly and all kinds of things, okay? So we want to accomplish those tasks, but not think about it in stages. The other thing is, from an REBT perspective, grief is not a problem. Grief is a normal response to a loss. And typically, if someone is just having straightforward grief, they don't really, it may not be necessary for them to be in therapy. That's a call for the client. But if the grief is interfering with them attaining their life goals, again, the similar kind of assessment that we would use with any other kind of emotion, etc., then of course we would help them with that. Or it is important when someone has grief to discern whether they're actually experiencing depression rather than grief. Okay, and you go to the DSM-5 and you look at whether they have 5 among the 9 or 10 symptoms that is required for the diagnosis of the depression, or you use the REBT conceptualization of depression. Okay, so again, let's refrain from using stages of grief, look at tasks of grief, and then always assess whether there's a depression or a complicated form of grief that is really preventing the individual from moving on. And that moving on can take a while. And sometimes there's cultural rules around the grieving process. For example, in Judaism, the first week you sit Shiva, and then there's a year-long progression of what you do and prayers that you say at the synagogue or whatever. In certain cultures, someone would be wearing black or having masses said for the individual. It can be really culturally conditioned in terms of what people do to help get them through those stages of grief. Number 9 is, and again, if you have a question, just send me a chat. I'm more than happy to address it. If I can. If I don't know, I'll tell you I don't know, and I'll go searching for it and get back with you. Number 9, I don't see why anger is a problem, this person is saying. When someone's rights have been violated, it's important and normal to experience anger. Okay, this isn't a question, it's a comment, but I do want to respond to this. And remember, in REBT, we do distinguish anger that is dysfunctional from, and there are different labels for this, the functional form of anger, which often people call righteous indignation. So anger versus righteous indignation. What's the difference? Well, the difference is in terms of whatever that emotion is, does it have you engage in behaviors that are helpful, or have you engage in behaviors that are not helpful? So for example, if you are enraged such that you are destroying property and harming people, and including yourself or putting yourself at great risk, that is not a helpful form of anger. That is certainly not righteous indignation. Part of the problem with anger is that often an individual who has kind of an issue with anger, they're repeatedly angry, they focus on being justified in their anger rather than is their anger helpful. And so that focusing on being justified rather than whether it's helpful can really get in the way and have somebody get stuck and actually do some damage with relationships in other areas of life, such as occupationally, etc. So it is important to distinguish whatever that emotion is called, if they call it anger and they think it's a helpful anger, to really help them assess whether it is helpful in terms of the consequences. We don't react to the word. We don't react to the word. If they say anger, we don't react to it. We assess whether it is helpful or not helpful, right? And then we use whatever the word the client wants to use. but then we know in our head whether it's helpful or not helpful, and help the client move toward having a helpful form of anger or whatever they call it. Two, the second point is anger is normal. It is quite normal, but frequently it isn't helpful. So often individuals with a lot of anger get disrupt relationships, form enemies, all kinds of things. And so while it's normal, it may not be helpful. The other thing is that if an individual is repeatedly angry, remember with those three things that we look at, frequency, intensity, and duration of an emotion, if they're repeatedly angry and that's really intense anger, they are activating the body physiologically, and cortisol is dumped into the bloodstream. And when that happens, the blood pressure can go up. That cortisol can really do some damage to blood vessels and cause strokes and high blood pressure, etc. So we really don't want an individual to experience high levels of anger over a longer period of time because it is really detrimental. It can also really mess up the person's immune response. And, during COVID, we want the immune system to be in the best possible shape so that it can fight off viruses and any other form of contagion. If the client changes the anger-causing beliefs, won't this get in the way of venting the anger? Somebody said, well, this idea that it is better to let your anger out than hold your anger in, so comes from Freud. We don't subscribe to that much anymore. And so the question is it better to hold anger in or let it out? The answer is neither one of those is helpful. If you hold it in or you let it out, it does the very same thing to your body. But Freud thought anger was like an energy that builds up and then it needed a safety valve. But it's not an energy that builds up in the body. Your head's not going to blow off. Nothing is horrible going to happen. Whether you hold it in or let it out, it may, if over a long period of time, be detrimental. So the way that we think about it now is that anger that is unhelpful is the result of unhelpful beliefs. And of course, if we can help the individual change those to more helpful beliefs, then yes, that will help the client in the long term. Someone did send me a chat. They said, so helpful emotions could lead to unhelpful emotions if the emotions themselves are not brought in check. I wouldn't say it that way. A helpful emotion is a helpful emotion. It means that emotion will help you attain your desired life goals. However, an individual could have a helpful negative emotion, such as sadness. Sadness is a negative emotion because nobody likes to feel it. That's what makes it a negative emotion, but it's a helpful negative emotion. Depression would be the unhelpful corollary to that. So let's say that an individual has sadness, but they also have irrational beliefs about their sadness. Oh, this sadness is horrible. I can't stand it. I shouldn't be going through it. And so they get angry about their sadness. Well, they started with the helpful emotion, sadness, but because of irrational beliefs about it, they generated an unhelpful emotion, anger about it. So it's not that the helpful emotion leads to an unhelpful emotion. It is that the individual could have dysfunctional beliefs about the helpful emotion, and those dysfunctional beliefs could result in a helpful emotion. An emotion doesn't cause another emotion. There always has to be beliefs about the emotion that would lead to another emotion. I hope that makes that clear, which is really related to this very next question. The person said, isn't anger a secondary emotion that is the result of frustration? Sometimes yes, and sometimes no. We can't say that with 100% certainty. If you look at the conceptualization of emotion, when you get to that issue of anger, you'll note that there are two forms of anger. One type is called a frustration-based anger, and the other one is an ego-based anger. Frustration-based anger is when we are trying to attain a goal and something blocks us in attaining that goal and we get frustrated. And then we have the belief that I can't stand this frustration. I shouldn't have to go through this. This is horrible. And then we get angry about the frustration. Ego anger is when we believe that we're unjustifiably attacked, and we get angry about that. It's about our ego, not so much frustration based. So the beliefs are somewhat different for the frustration based anger and for the ego based anger. Okay. Typically, for both, the inference is that an important ethical principle or moral principle or religious principle has been violated. Okay? And then we develop some dysfunctional beliefs about that, and that ends up. So, another thing, though, is there's another emotion that I covered in the conceptualization of emotion, and that is the emotion hurt. Now, hurt is a complicated emotion. Hurt is the primary emotion. We first experience hurt, but then sometimes that hurt will get expressed as anger, and sometimes it gets expressed as depression, and sometimes both depression and anger. Okay, so if the first emotion that the person experiences is hurt, and then they get angry, we say that the hurt is the primary emotion. And the emotion that they have about being hurt is angry, then anger is the secondary emotion. If they have hurt and then they get depressed about being hurt, then the hurt is the primary emotion, and the secondary emotion is the depression. So one of the ways that we say that is that the secondary emotion is a meta disturbance. Why do we say that? Because it is a disturbance about a disturbance. So let me give an example. Let's say I'm having a lot of anxiety, and I have it over a long period of time. And after a while, I start believing I can't stand this anxiety. It's too much. I'm such a loser for having this kind of anxiety. Those thoughts may have me become depressed about being anxious. The anxiety is the primary emotion. The depression is the secondary emotion. And another word for that secondary emotion is what we call a meta disturbance, a disturbance about a disturbance. Okay, so there can be lots of those, and we typically, when we're doing counseling, always check for whether there's a meta disturbance. Okay, and I just have 3 more questions, and then we will be able to wrap it up for the evening, unless you have some more questions. The question number 11 was, aren't emotions culturally determined? Again, an excellent question that has a couple of different dimensions to it. Emotions are universal. All people, every people group has the capacity to experience the full range of emotions. However, where culture comes in is how is that emotion expressed? Okay. And sometimes that differs from one culture to another culture. Some cultures are a bit more tight-lipped. Other cultures freely permit the expression of emotion. We often joke in my family, my wife is from a real waspy kind of family, and they didn't show a whole lot of emotion. My family, we were out there emotionally. We would get upset, and then we go, oh, what do you want to eat? And so when I first visited my wife's family, I went, oh my God, they're dead. And then she said that when she came to visit my family, and actually it was the first time she came to visit my family was on Thanksgiving, she thought that it was utter chaos. So the culture within our families was quite different. And I notice that when I'm in New York, um, we can often be really free in expressing our emotions. And then I've been in other parts of the country where I lived in Connecticut for a while, and there wasn't the same kind of tendency to do that. So it's just different in different places. But we all have the same emotions. We're all human. We all have the full range of emotions, but the culture can condition the expression of those emotions. And it's tremendously important to know that, or to have the client teach you about that, or to consult someone from that culture of your client, so that you have a better understanding of what would be the norm within that particular culture. 12, sometimes I know that I'm feeling something, but I don't quite know what emotion it is. Is there something wrong with me? No, there's nothing. There's nothing wrong with you at all. Although, if you can't come up with a label for any of your emotions, that is a condition. We call that alexithymia. And it's not that common, but it's not uncommon that people just don't have the vocabulary for the emotion. They can't identify what they're feeling. My wife calls that a husband, but I went, Carol, you just have a biased sample in me. So yeah, someone could have alexithymia. More often than not, though, is that we in our body first experience some kind of physiological arousal, but the brain has not quite made its best guess at an emotion. It hasn't come. The brain makes a best guess of our emotions. It's not a certain process that the brain goes through. And each emotion doesn't have its own neural pathways within our brain. We experience arousal, we have physiological arousal, and then the brain makes a best guess of the emotion based on the inferred threat that is present. And sometimes that takes a little while, and some people just find it a little more difficult to be more aware of what's going on within their body, etc. So yeah, this is really common occurrence. There's nothing abnormal about you at all. Sometimes we just have to help each other figure it out. Some people understand themselves by talking to somebody. Some people go inside themselves and consider it. We're all different, and that's perfectly legitimate. The last question, and again, if you have one, please send me a chat. It says, I love this question, is the goal of REBT to have clients be calm and never experience anxiety, depression, rage, and so forth? Isn't having the full range of emotions part of being a human? Absolutely, it's a part of being human. And it's not our goal as therapists, particularly REBT therapists, to have everybody calm all the time. I mean, actually, calmness could be really, really dysfunctional. If something really exciting happens and and um, and you're just really calm, people are like, "What's wrong with you? Why don't you jump in and enjoy the happiness with?" And then you don't get to have the happiness. You're just you're kind of laid back. I mean, one definition of psychotherapy is the goal of psychotherapy is to reach that state of mind known as Los Angeles. That's not REBT. We want you to have the full range of emotions, but if you are having a lot of dysfunctional emotions that are really sabotaging you and causing you deep pain and interfering with your life, yeah, we want to help you to the degree that we can with that. But you know what? We are going to have times when we experience these really unhelpful negative emotions, and we're going to have dysfunctional behaviors. That's a part of being human. And that's why that's brings up another really important concept within REBT, and that is unconditional self-acceptance. We are all irrational at times. When something bad happens, we're not in our most rational state. and we will experience all kinds of dysfunctional emotions, etc. So I think what we want to do here is, you know, just, be kind to yourself, accept yourself unconditionally, and realize there are times when you're going to mess up. That's a part of being a human. So we call that unconditional self-acceptance. You may not like it when you're really irrational and, you blow up and get angry or get depressed or whatever, but it happens at times. And seek help if you need to. On the other hand, we also like to help clients have unconditional acceptance of others, because let them be fallible humans too. Accept that we are fallible humans, we will mess up, and that they are fallible humans, that the world is fallible, and life has some stuff in it that's not always great. But accept it, because accepting it, acknowledging it, not running from it and not denying it, is one step to help overcome the dysfunctional emotion and those behaviors. So, yeah, acknowledge it, accept it, that it's there, accept yourself unconditionally. Don't beat yourself up, because if you unconditionally accept it, let's say you have an anxiety condition or depression, but if you can unconditionally accept yourself with whatever you're going through, you are going to be more resilient, and you can help your client be more resilient too. In REBT, we don't think it's ever helpful. We don't think it's ever helpful to label someone negatively because of an emotion that they experience or because they have some dysfunctional behavior in periods of irrationality. Okay, so that's really important concept. And somebody just sent me a question. In the ABC model, do we ever hypothesize about the activating event or the critical activating event, or is that something more concrete? I'm not sure that I get the full question, but if I got it correctly, do we sometimes hypothesize about the activating event or the critical activating event? Let me give an example of where I have caught myself doing that, but then I check it out with the client. Sometimes when clients come in, they postpone coming in until they're feeling pretty bad sometimes, or they're nervous about coming in. They tell me sometimes that they've driven up and back and forth in front of my office before they could get up the courage to come in, or even they dialed the phone number and then as soon as they heard my voice or my assistant's voice, they hung up, a few times. This is not the easiest thing for humans, to acknowledge that we want some help sometimes. And so sometimes when they come in, it's like, boom, they let everything out and they're just going on and on and on and on and on. And so I hear about an emotion, I hear all kinds of situations. And so I'm not quite sure when they have that emotion, which of those situations is most relevant to the emotion that they were talking about, because they brought up so many potential situations. So one of the things that I say when someone does that, and believe me, they will do that, especially very verbal individuals, I go, wow, there's a lot there. Among everything that you just said, what is the most significant event that you mentioned that is most significant to the emotion that you want to work on? So see what I did? I'm helping them tell me what the activating event is. And once I get the activating event, the general situation, I'll go, okay, inside that situation, what part of that situation is most relevant to the emotion? So think of the activating event as the larger situation, but the critical activating event is the relevant part of that larger event that is more directly related to the dysfunctional emotion and behavior. So yeah, you may have a hypothesis, but and it's good. It's good to have a hypothesis, but always recognize your hypothesis as a hypothesis. Don't think that you fully understand the client. So if you form a hypothesis, float it out there with the client and ask them whether that's the case or not, And if it isn't, some of them will tell you. The only time where that can be become a problem is if the client is a really dependent individual. So if you get a sense that they're really dependent, they're going to just take whatever you say and make it and turn it into the gospel. Then, of course, you need to be cautious there. So the person said, so ask questions based on our hypothesis that guide us to understand the client. Absolutely, Brian. Absolutely, that's what we want to do. You know, in logic, they talk about deduction and induction, and I'm sure you've heard that, where deduction starts with a big concept and moves down to an actual observable thing, and induction begins with particular events and then comes to a generality. But they fail to tell you that there's a third kind of thinking that is tremendously important, and it comes up in exactly what Carolyn was asking me about. This is what we call abduction or retroduction, and it's like this. We see some surprising event or situation, maybe with our client, a particular emotion that we're surprised or curious about. And then what we do is, well, hypothetically, if this was the situation, then they would be having that emotion. And then we go, and so they are having that emotion. So hypothetically, that's the situation. But see, we don't say for certain, we go hypothetically, that's the situation. So always embrace it as a hypothesis. And in fact, spend time just brainstorming hypotheses, but always, always, always check them out with the client. Okay. Any other final question? We've had a full evening. You guys have asked some really good questions, and the people that emailed asked some really, really great questions. I hope that gives you some more clarity about this whole conceptualization of emotion, and just to be good to yourself. Unconditionally accept yourself and let it soak in for a while. If you have some questions, just email me, and I will certainly set up a time where we can talk through that. Several of you did it this week, and it was really, really good to hear from you and talk to you and see what you experience as challenging. And some of you knew you just wanted reassurance from me that you were on the right track. But no more questions. I want to thank all of you very, very much. And I hope that you stay tuned. Every week I do these. Sometimes it's on a Wednesday, sometimes it's on a Thursday, because my wife and I are coordinating schedules watching the dog. So one of us will be on a computer at a time. So thank you all very, very much. I hope this has been really helpful, and you have a great rest of your day and a good rest of the week. All the best. Bye-bye.